This is Larry Greenley. Our topic today is healthcare reform from a doctor's perspective. We're very happy to have with us today Dr. Jeffrey Glassheim. He's an allergist and immunologist at Children's Hospital of Wisconsin in Neenah, Wisconsin. He treats both children and adults, and he's also assistant clinical professor of pediatrics at the Medical College of Wisconsin in Milwaukee. So I'm really glad to have you here today. And we're going to start right off with a big picture question, and that is, what is your vision for what medical care should be?
Well, I was born a little too late, perhaps, for some of this, but I would imagine that sometime between the late 1960s and about 1990, there were a preponderance of indemnity type of plans where people paid for their services when received or worked out payment arrangements with their health care practitioner, and then filled out some paperwork, sent it into their health insurance company, and got a portion of that reimbursed. And that was pretty much the way it was till the advent of HMOs and PPOs and so-called managed care, circa 1990, give or take a few years. And that's now hard to believe that we barely have 2 decades of that under our belts. But truthfully, I think a little bit back to the future might actually be, in essence, a pretty good summation of how we should be proceeding.
I've heard you, a couple weeks ago, I heard you on a panel. You talked about being in practice in California, solo practice and things like that. What do you see in terms of that contrast?
Well, yes, I moved here just past the 4th anniversary of moving into Wisconsin with my family, August 15th, 2005, after a 12-day, 2/3 cross-country trek from California. I spent the better part of 13 years in California, the first 2 of which was my last 2 of 8.5 in the Army Medical Corps, and then subsequent 11 that ended in about a 7 or 8 year run in my own private solo incorporated practice. And much to my amazement, there are very few entrepreneurial, independent-minded practicing physicians in the Fox River Valley region. I'd say literally 1 or 2% of primary care physicians are not employed by one of the 3 dominant healthcare corporate systems in the area, and perhaps give or take 50-50 on the specialist side, although the 50% that's independent is probably not so independent as they think, as they have large contracts with the same healthcare corporate organizations. So in sum, though I thought I did it in the toughest state to do it and in the toughest decade to do it in, i.e. the 1990s in California, when HMOs were on the real huge upswing, though we don't use the alphabet soup nearly as much now, HMO, PPO, POS, etc., it's sort of become the lay of the land, and it is what it is. Quite frankly, the corporate practice of healthcare, such as it is here in the Fox Valley region of northeast Wisconsin, is actually illegal in many states. You can't have practice of medicine dispensed by salaried, employed physicians of a large healthcare corporate entity that they never have a chance to actually have an ownership share in many, many states in the United States right now today. So I think this facilitates some of this mind speak, and you get these CEOs of the organizations kind of wafting back and forth. They're actually on the front page of the Post-Crescent again today, this time for the first time coming out not in favor of the public plan, which I think you'll be asking me about a little bit, I'm sure. So it's good to pay close attention, because it's tough to keep the name straight without a scorecard.
In your vision, you mentioned if you could go back to the future or turn the clock back, it could be better. In particular, what would be better about it for the patient?
Well, back then, and in very small part today, there were systems whereby the patients had a sense for what the price of the services were. Services, products, medications, etc. Why? Because they got the bill directly from the providing organization or practice, physician, pharmacy, what have you, had to pay out of their hip national bank, if you will, and apply for reimbursement from their hired hand, their health insurance corporate entity that was in place to prevent major fiscal catastrophes. That's why they called it major medical, which you almost don't hear those terms anymore. There is an attempt, and has been now for about 4 or 5 years, to go a little bit in that direction, the so-called healthcare savings accounts and high deductible type plans closely mimic that which I just summarized. And many people think that obstacles to increasing those ought to be removed. And so things like that and others that we might get to, I, as most physicians, are in favor of reforming. And it's not a matter of being pro or against healthcare payment or healthcare insurance reform, which are the preferred terms, but in fact, what actually are we doing to get to that point?
What's your reaction been to the really widespread opposition to government takeover of healthcare during the last couple of weeks, all these congressional town hall meetings, and what have you thought about those?
Well, in a sense, it's a mixture of relief, gratification, and I told you so. And that might sound surprising compared to, let's say, 6 or 7 months ago when the current administration first took power on January 20th, just over 7 months ago yesterday. But when you really stop and think about it, what's different here is that this is an extremely intimate, personal issue, unlike the macro mega issues of credit reform and banking reform and other corporate reforms such as the automobile industry and conglomerations of all 3 or 4 of those. This strikes at the core of personal responsibility, and I think you're seeing the flash of that in terms of what you rightly call a rather vehement protestation of this, ironically most vehement upon the recess of congressional representatives, traditionally making up the month of August. So what usually is a very slow month of news coming out of Washington, D.C., I think represents the single greatest reprisal concerning a domestic and not foreign policy issue, perhaps in the history of the land.
Much of this concern in the town hall meetings is about a government takeover of healthcare, as it's often stated. And on a scale of 0 to 100%, how far are we along the path toward completely government-run healthcare?
30%.
About 30%.
I would come out and say 30%, and that comprises Medicare, all the vast array of medical assistance programs, military socialized type medicine model that I worked in for over 8 years, and the VA system, which is not quite military as many people mistakenly think, but is certainly government-run, government-administered, and government-employed healthcare professionals. So if you add all that up together, I think it's conservative to say getting close to a third already.
So we're not at 0. So this idea of a government takeover is just that we're moving along that path, and people are concerned about going further.
We are, but the difference is Medicare you get into based on age, medical assistant you get into based on income, and the VA and military you get into based on having served. Some of those you could say there's a choice involved, some you could say there isn't. But in the current maelstrom, the concern is that there would perhaps very much likely be no choice at all at some point in time. That and also these hidden trigger mechanisms, i.e. example, make a change in your employer-provided, employer-paid, in part or in whole health plan. Just make a change, up or down, in benefit. And one of the trigger mechanisms shunts you into the supposed public plan that's now very recently in jeopardy just here in the last 3 to 5 days. So it's just, a lot of people are up in arms about this, perhaps rightfully so. I think it was a major error in strategic practice by the far left representatives in Congress especially, who our president has enabled to basically write the bill, almost has directed to write the bill, with very little input from the middle and the right. And such as it is, it's extremely unlikely that much of this will ever get put into any kind of packaged bill because it's been unclothed, if you will. The curtains have been parted, and once people know about this, they perhaps will be eviscerated from any final bill that would come to pass, if any, comes to literally be passed.
Under our current system of health care, what is the impact of the Medicare and Medicaid patients on the cost of medical care for those patients who have their own private health insurance or those that don't have insurance? How does that impact the cost for them?
That's probably a tougher one and not easily answered. I would say from my own experience, especially when I had my own practice in California, in Central California, from 1997 to 2005. I would say that because more and more of the private healthcare insurance companies are mandating fee schedules that closely approximate that put out by Medicare each year, that probably is ratcheting down somewhat, significantly, the cost of care that's mediated by these healthcare insurance companies, as well as through them, the employers who hire them to manage their employer-paid plans for their employees. The individual patients, however, having a minority share of the cut of the responsibility, therefore save markedly less than the actual corporate structures save. For the folks who don't have insurance, most of those people today fall into two categories. One, they have plenty of income and just can't get a good policy at any reasonable cost and decide to self-insure. And those people can actually negotiate with practices, perhaps a little less so to pharmacies and hospitals, but they can. And then the other folks, I would again subdivide into two, which is the safety net catches the poorest of them, and that's, of course, the medical assistance net. And then the other portion is the part that is, I think, the part that really, those are the folks that need the help the most, which are the working poor whose incomes exceed the medical assistance, Medicaid type of safety net, but falls far short of being able to buy their own plan and don't have an employer to sponsor them. That group is perhaps, most people estimate, between 8 and 16 million of this purported 40 to 48 million figure that you most often hear bandied about. And so that's why you're seeing this reprisal of why upset the apple cart of a 300 million population country for perhaps 3 to at the most 5% of that population that actually is in need of some assistance that might be mediated by reform.
With the people with private health insurance, I guess you're saying that the payments that are made on behalf of them are being ratcheted closer to Medicare by negotiation?
Each year we would see that new fee schedules would come out, despite increasing premiums that kicked back in the early part of this decade after they had fallen through the 90s due to HMO penetration. But yes, despite that, the fee schedules continued to actually drop in terms of what physicians and some hospitals were paid. And so the cut that was kept by these billion-dollar health insurance companies began to increase. So one shouldn't assume that because anybody, least of all a physician, is against much of what's been publicized as part of House Resolution 3200 and other such bills, doesn't mean we're pro-health insurance company per se. Most of us are fed up with them, and that's why we're okay with some structural change and some true reform of healthcare insurance policy. But that, to me, ought to be taken as doublespeak for a government-run, government-mandated public policy type of plan structure. That's a totally different ballgame.
Under H.R. 3200, the tri-committee bill that's in the House right now, I think that the medical care, the reimbursement is indexed to or to be identical with Medicare payments, or maybe a few percent above Medicare. What impact would that have on doctors' practices if that is instituted?
Well, the impact has already been felt by the caps in the Medicare fee schedule that get more onerous each year, and therefore there's a dearth of physicians in many communities that even are willing to be continuing to be contracted with Medicare, and you have more and more physicians deciding to so-called opt out. When you opt out of Medicare, which I did for 2 years towards the end of my private practice time in California, you have to actually file a fairly decent amount of paperwork, but not insurmountable, and you need to renew that every other year. It's very much not a passive way to go, and that's, I'm sure, by design. But it is happening, and it's happening to, of course, the detriment of people 65 and over who have no other means of securing their health care. And thus we have this dichotomy of less and less physicians and other health care providers participating in Medicare, while you have more and more a foray into eventual bankruptcy of the program where vigorous and structural Medicare reform not be undertaken, which I think is definitely something that's extremely important to proceed with out ahead of that which is creating all the hullabaloo this summer.
If 3200, HR 3200, if that would be passed, and all these tens of millions of new people would come in, plus probably tens of millions of more people that would end up moving from their private health insurance into the public plan, if this would take place, then the fees would all be set at Medicare at the present level. Would you stay in medical practice in that kind of situation?
Myself being mid-career and have lived below my means for a number of years, I, speaking for myself, A, still enjoy medical practice enough to answer yes to that question, and B, can afford to, even under what surely would amount to a cap in potential earning capability for healthcare professionals under this system. I don't think there'd be any doubt about that. The question about what that does, to the masses of professionals out there is probably not too different than if a cap was established on airline pilots, police officers, general officers in the military, teachers, or perhaps sanitational engineers for that matter. No disrespect intended to any of those groups. If you have a capitalist society that you then you impose artificial caps upon their earning power, you'll always get a few folks who just have a passion for that, that would be attracted to it almost if it was pro bono, and some maybe who already had made their mint elsewhere who'd even be willing to pro bono. And that's wonderful that occurs. But the truth is, they don't call it work because it's a vacation. It's still a job, and we still have families to support, and some of us had or still have businesses to run, and therefore employees to actually support in terms of carrying a payroll forward. The realities would be that things would suffer in terms of leading towards this rationing concern, which is, along with cost, I think, the two-headed monster of this plan.
So you would strongly consider not continuing as a physician there?
I myself, as I spoke, I still retain a passion for it, and because I live below my means, I myself would be able to, at some institution of CAPS, would be able to afford to continue for a bit longer, perhaps. But I know that many others could not,
many others would not,
won't, as the case may be, in a matter of degree based on their own personal situation. More importantly, folks would be discouraged, again, accepting the most idealistic in the bunch, which I have a healthy respect for those folks. But in terms of continuing to supply the ranks of physicians that is eroded by retirement, you wouldn't get the cut of students applying to medical college that you do currently and for about the past century, because quite frankly, Economics 101 takes over when you have an unbelievable push in demand for services and no purported increase in supply, or a disproportionately small increase in supply. There's going to have to be rationing, and you're going to have a lower quality and a lower cut of ability and intelligence and education level of folks that are looking to get into the field. Sad but true.
What this kind of situation would mean for the quantity and the quality of students, I guess that's what you already said, that this would...
Because of that, I actually have more concerns about this as a patient than as a physician, to be honest with you. That's a concern. When you have both cost and rationing as the two major concerns, either 1-2 or 2-1, depending on who you're talking to. If you're talking to someone below 60 or 65, it's mostly cost. If you're talking to someone nearing 60 or even a little younger, certainly rationing is probably the biggest personal fright factor here. This is a recipe for absolute disaster, and I said all along, I don't think that we're going to see anything close to this passed. If we see something passed, it might have to be a politically expedient. I would never sell short those on either side of the political spectrum who wish to say they did something and would rather pass fluff than say that nothing got passed. But if that fluff follows the Hippocratic oath that we swear to, which is first not to do any harm, I suppose I wouldn't be averse to that in this case.
Under this scenario, what you would predict for the future of American medical care in general. I think we've really covered that, though. Is that?
Yeah, I don't know about the term prediction, because I think that's certainly a bit less certain than some of the things that we've discussed here this afternoon. I would just hope that cooler heads prevail. I am very glad to see the empowerment and the engendering of the involvement that we've seen. I have less concern about whether that comes from the grassroots or whether there's some organization behind it, because if it was just the organization and there was no power behind that and no foot soldiers behind it, it would be so much hot air. It's the fact of the masses that are rallying behind that. That's the real power of this. I was giving out an article and some information about contacting your representative with your content or discontent, as the case may be, to these concepts way before any were packaged into a House resolution or come out of any of their or Senate committees. I published a letter in the Post-Crescent, I believe, April 11th, and I've been handing it out with the telephone contact information for the representatives and senators, thinking at that time, who knows, between the 4th of July and the recess, we might get something. And that was about 4 months ago now. And we're basically right at the midpoint between when I published that letter and the latest deadline for passage that the President has put forth, which is, in essence, Christmas Eve, before that holiday recess. That's, in fact, we're almost exactly at that midpoint between mid-April and mid to late December. So I suppose, time will tell all, as it always does.
One major topic that's been coming up the last couple of weeks, the Senate Finance Committee is working on what's called a bipartisan compromise bill. And they haven't admitted for sure, but they're talking about a health care cooperative substitution for the public option. And what do you think of that? Do you think these things are they really a valid non-governmental entity that could work, or are they more of a deceptive placeholder that could just allow legislation to be passed and then transition to the public option or the government system?
One hates Larry to be skeptical, which, of course, if I fall in with the presumption in the latter part of your question, then I guess I could be accused of being that. But truth is, we've just not seen enough in this discussion to make one not at least entertain the prospect that indeed the latter portion of your question that you surmise could indeed possibly be the case. Having said that, I'm willing to hear what they have to say in greater detail after Labor Day. It certainly sounds at least a tad less onerous than what we've mainly had filling the airwaves most of the summer. So I'm okay to let that play out as long as it's looked at with a jaundiced eye.
A recent Rasmussen poll shows that 54% of Americans would rather that Congress just not pass what they have already introduced and not take up legislation like that this year. What would you recommend at this time that people tell their representatives and their senators about the health care bills?
Well, I'm often accused, not least by my own wife, of not being economical enough with my verbiage. So to put it succinctly, I'd use 3 words: tweak, don't topple. This is something that certainly has enough merit to it to tweak the system, if you will. That would be changing the tax laws to make individually purchased plans non-discriminated against compared to employer purchase plans, removing the obstructions for more health savings accounts to match up with these high deductible plans that closely mimics the old major medical type policies. Certainly vigorous Medicare reform is absolutely mandatory, or there's no question that will be completely out of money. Already there's trillions of dollars, mandates promised, unfunded. These are the issues that need to be tweaked, and I use that term obviously somewhat loosely, because those are not small things, especially the latter. However, they certainly don't come close to toppling the entire system, knocking it down.
Which is how you view
removing the garbage, and then starting with a new foundation and framing from that point, to use the construction metaphor. It's mind-boggling that could even be proposed in the 4th, 5th, 6th, and 7 months of an administration that, before it got formally proposed this spring, already had committed to multiple trillions of dollars of spending, budget, omnibus spending, future promises, mandates, etc., toppling balance sheets everywhere, vigorous corporate takeover of industries and what have you that we all now know of. Who knows? If this had put first ahead of those things, we might have had a bill by now. The fact that it's coming in distant order to what went on in the first and second quarters of 2009 might truly prove to be the death knell of it for at least 2009. And as we found out in 93 and 94, it could take another decade and a half till it comes back. I don't see that. I think we'll have something. I don't know if it'll be this year. But if it's a tweak and not a topple, I don't necessarily know that that has to be a bad thing. Politically speaking, which I'm less of an expert on, it seems mind-boggling to me that they wouldn't wish to put something forth in a bipartisan manner and not just try and ramrod it through, as some are saying they might try to. It's hard to believe that that could still be the plan after the goings-on of the past month.
Yeah. Do you have any other aspects of the healthcare debate that you'd like to?
Well, the big one for me is tort reform. You know, reform was used after the word tort for a lot longer than it's been used after the words healthcare, healthcare payment, or healthcare insurance. And I think it's a large measure the fact that political action committee spending by trial attorneys dwarfs that by physicians. Because, again, many physicians are basically now salaried employees, and though some attorneys surely are, the trial attorneys are surely not often finding that model of employment. And so they continue to fill the coffers at huge ratios to 1 compared to physician tax spending. And consequently, we don't have tort reform at a federal level. Some states have taken the lead for many decades already. I moved here from California, where there's been a so-called micro cap on pain and suffering awards of $250,000 in place since the early 1970s. It's still, 38 years later or so, still $250,000. Wisconsin was ecstatic to pass 3 times that only a year or 2 ago, after an initial attempt to have a dual 450K and 550K cap, which was declared unconstitutional by our state Supreme Court. And thus, for 9 months after that passage, there was no cap again. And then since the springtime of 2006, for about 3 years, there's been a $750,000 cap in place. And many physicians even jumping for joy over that, which I guess compared to nothing, that's important, but it's a far cry from what needs to be in place. And last time I checked, Wisconsin's cost of living is not triple California's, and yet our cap is. Many states don't even have that, and tort reform at a federal level would trump all these differences, and I think is what's indicated here as part of a grander form of reform.
Okay. Anything else? Any other aspects?
Well, I just hope that that people continue to voice their feelings about this, both pro and con, and hopefully elucidate them and do so in a professional and yet personal and yet respectful manner. It does no service to either side of the fence if people try and drown out the opposition. And I think that I think we have the ears of our representatives that are based in Washington but currently scattered throughout the country on vacation and in recess, and we'll surely see what happens here in the next few weeks.
Yes, we will. Well, thank you very much, Dr. Glassheim. Thank you.
No problem, Larry. Thanks for having me.
All right.